Okay, so we are going to move into chapter 27, which covers labor and delivery. This is a fun chapter. It is a lot of information, a lot of details that just even people that have experienced it still don't know or comprehend without studying it. So it is really interesting. It's kind of a miracle, and I hope you learn something. It is fun. So to start, for the content, it is important to understand that birth was not always done in a hospital setting. Um, it's just there are other places that people deliver outside of a delivery room, right? So in traditional hospital settings, the environment is very sterile. They tend to limit visitors. It is in a delivery room, and then a lot of times they transfer into a postpartum room. But it's important to understand that there are birthing centers too. These places are much like hospital settings, but they're structured more like a house, as you can see in these photos. They can be and are good if they are affiliated with a hospital, but often are privately owned and operated. So this picture on the top here is one that would be a birthing suite. So it's set up much like a home setting, but it's not this patient's actual house. And then in some cities or larger cities, these types of birthing suites are attached and or very near to the hospital in case there are emergencies. The community you live in limits your options, of course. So your demographic area and where you are located to those types of facilities changes. So like, of course, in our experience at Jane Phillips, we don't have a birthing home. Or a birthing center. We have a delivery unit at our hospital, of course, but we don't have any other types of options as far as midwife assisted birthing centers. Maybe one day, but for now, no. In Tulsa, there are. So it's important to understand that people's options, people might travel to have that as an option. So the hospital setting, of course, like I said, is more traditional. Some hospitals are set up with delivery rooms, and then patients are transferred to postpartum rooms. So where they have the baby and then where they recover are different. And some hospitals are set up so that they labor and deliver and then receive all their postpartum care all in one room. The perk to that is that there's not a handoff of nurses to different areas of the unit. It aids in the continuity of care. So as you can imagine, there are so many details to be reported and handed off. Not only do you have one patient who just delivered, now you have a baby. So the handoff of that can be complicated. There's a lot of information that can be missed. And so in facilities where they do delivery and have postpartum all in one, the continuity of care remains the same, where there is a lot more risk for error, I would say, in hospitals where they do separate. Now, I will say it is more common, and it is set up at Jane Phillips for them to be separate, labor and delivery and postpartum. So I would love to see a push where that changes in the future, but it is common that you will see a labor and delivery room and then postpartum rooms. Okay, so of course, like we talked, there are many places in which people have babies. So home births can be common. They were not necessarily common until the 1900s, but it is a very popular option now. There was a renewed interest in home births as women increasingly wanted more control over their birthing experience with a desire for decrease in technology. So if you've ever had a baby, or soon you'll see in clinicals, there is a lot of technology and medical care that goes in with delivering babies. There's a lot of monitoring in hospital staff, continuous monitoring and medications and IVs. There's just a lot of medical care. And so some women want a more natural experience, and they are not interested in a hospital setting because they want to decrease that technology. Even with that desire and increase in population, it's still less than 1% of nearly 4 million births annually that are done at home. Keep in mind, it is not an option for all women, or shouldn't be per se. It is not intended for complicated pregnancies. Some complications, even for people that do elect to have home births, turn into a transfer to hospital care. So something might be going on, or maybe during the delivery the fetal heart rate drops, or it's been 40 hours and the baby hasn't been delivered. They may choose to transfer via ambulance to a hospital setting, which is of course traumatic. Sorry for that. Most home births are attended by midwives or doulas. It's not, I would say it's even less common for women to facilitate their own deliveries. There is usually someone else, like a midwife or a doula, that assists them and helps them with that process. Occasionally, physicians, I'm going to go back here. So, occasionally, physicians and nurses or physician's assistants will assist with home births, but I would say that is pretty rare. Okay, so I've already moved into the next slide here, but we're going to talk about what a normal labor looks like. What does that mean? The exact onset of labor, like what causes all women to go in labor, the theory is still not completely known. Every woman's experience is very different. It's kind of one of those things that it's sacred to the family and it's a fun story to tell, and there are similarities between women, but most women's experience is not exactly the same, and there's not one true mechanism that is exactly the onset of labor that they can pinpoint. In general, though, the uterus begins the process of labor once the fetus is matured, of course, and ready. So the exact phenomenon is still not known. Theories stem around these two things, so both mechanical theory and hormonal theory. So the mechanism of the uterus stretching is one thought, that it becomes so stretched out, and because it is a once hollow organ, once it reaches a certain state of distension, it spontaneously contracts and empties, much like the stomach or the bladder, right? The bladder is a hollow organ. It fills with urine, and then once it is large enough, it contracts and empties, same with the stomach. So that theory is considered similar at the mechanical theory, where the uterus gets large enough. Once it's distended to a certain point, the onset of contractions kick in. And then the other theory is that it is hormonal, that the stimulation of oxytocin joined with the withdrawal of progesterone, the increase in estrogen, and then fetal cortisol levels all play in the onset of labor. So impending labor, what are things that you're going to see that would tell you labor is coming? So signs of lightning, it's called. These things can happen as early as 2 weeks before the onset of labor. Women may notice that the fetus has dropped or has lowered, which is also known as lightning. So that feeling of the baby suddenly being lower or dropping into the pelvis, that's the definition of lightning. Urinary frequency kicks up more. Why is that? So as the baby drops down into the pelvis, the pressure on the bladder and the space for the bladder to fill becomes less. So there's less room for urine, which means the bladder has to empty more frequently. Women can breathe more easily. Why is that? So as the baby is, as the baby grows, it becomes very much a thoracic. The uterus becomes a thoracic organ. Remember, it starts in the pelvis, the size of a pear. It comes up into the abdominal space and even into the thoracic space. So as that baby gets bigger, the mom has a hard time breathing. Well, now once lightning happens and the baby drops into the pelvis, now the woman's lung space and her ability to take a deep breath is much better. So, of course, also there may also be vaginal discharge or seepage. In some cases, this can be urine. Some women might think it's vaginal discharge just because of the pressure on the abdominal or the uterine. The pressure from the uterus might cause seepage of urine from the bladder. But it's important to understand that it may also be amniotic fluid, indicating the concern for ruptured membranes. Okay, so again, vaginal discharge could indicate ruptured membranes or amniotic fluid that's leaking. It is important to test regardless of if the woman is unsure if it's urine. That sometimes can be embarrassing for women. They might be like, oh, well, maybe let's wait it out and see, because what if I'm only peeing? It is important to test the woman when she is feeling like her sac could have ruptured. We do that with nitrazine paper. It's a little strip of paper where they take the liquid and they swab, usually the vaginal area. They'll swab it and then place it on the nitrazine paper. If it becomes blue, she is positive for a ruptured sac, meaning that that fluid is amniotic fluid. If the nitrazine paper is blue, she's positive for amniotic fluid. There's a procedure for this. It goes through it on page 813, box 27.1. I would encourage you to look at it. It goes through the process for how you test. But it's the most important to know that nitrazine paper is to test for amniotic fluid, and that also if the paper becomes blue, that it is positive. Okay, and then also things to know if her membranes or her sac is ruptured. Typically ruptures with the initiation of labor. However, if she is not in active signs of labor and she's not having any other signs that the baby is coming other than that her membranes have ruptured or that there is amniotic fluid leaking, induction is necessary at some point. It's important. This is an important number to remember, but from the time the membrane has been ruptured, it's 24 hours is the safest for delivery. Let me rephrase that. So the baby should be born within 24 hours from the time the membranes are ruptured. If membranes are ruptured and the woman is not in labor, again, it often results in induction of labor or even increases the need for cesarean if labor is not progressing quickly enough. So if they're pushing 24, 25, 30 hours of labor from membrane rupture, they'll often move into a C-section delivery to prevent complications like infection. Okay, so some other signs of impending labor. Something called bloody show. What is that? So it's as vaginal discharge increases, as she comes closer to full term. Sometimes what we call a mucus plug. It's a secretion, a thick mucus that is right near the cervix or at the cervix. It is blood tinged, and often as that starts to shed or leaves the body as labor is being initiated, it can be blood tinged, and that would be what we call the bloody show. The mucus plug is intended to keep the cervix occluded during pregnancy, but of course, once the woman is moving into labor, the mucus plug leaves the body. And because it is blood tinged, it often is referred to as bloody show. So they might ask her, are you having any bloody show, or are you having any clear drainage? Okay, so other things that happen for signs of impending labor are what we call Braxton Hicks contractions. You might have heard of these before. So it is back pain and contractions of the uterus, but it is really important to understand that they are typically irregular. They can be mild and even moderate, but they do not dilate the cervix. So they're often triggered by movement or lifting, but they still do not progress to cervix dilation. So they can even increase in their severity and cause even some moderate pain, but the cervix doesn't change at all. So that's the difference. If the cervix starts to dilate, they're no longer Braxton Hicks contractions. And it's important too to understand Braxton Hicks contractions can start really early. Some women notice them 20, 24 weeks. It just depends on how irritable that woman's uterus is. So, and another common thing that people experience near impending labor is what we call nesting. That is the excessive amount of cleaning and cooking and preparing for that baby. It's like an innate natural response for the woman to want to get everything ready. It's a sudden burst of energy, sometimes can be accompanied with nausea and vomiting, even some mild weight loss. But nesting is very common near the end, and when the woman is getting closer to delivery, her body is trying to prepare. So the true onset of labor is effacement and thinning and shortening of the cervix. So these are all signs of impending labor, but the true onset of labor is cervical shortening, effacement, and thinning. Okay, so it's important to understand the difference between false labor and true labor. So false labor might look like a few of these things, but it's important to know a lot of women will experience this. They think, oh, it's time. They're really excited. They're having Braxton Hicks contractions. They're getting stronger, more intense. She's nesting. She might have even lost her mucus plug, but contractions really aren't following a consistent pattern. They may vary in length and intensity, but not consistent. Most noticeable in the fundus, so the contractions are up high. The uterus is essentially practicing. The upper portion of the uterus provides force during the contractions, during labor, and so the uterus is practicing. A lot of times we know it's false labor if the woman slows down. Say she's nesting and she's very excited and she's getting things ready. If she stops and she lays down, a lot of times whatever types of contractions she's having at that time will start to relax or slow down. The cervix may at this time soften and it might change. She might even lose her mucus plug, but there's no true effacement or dilation at this time. And then also there's no change in fetal position. So with false labor, the baby doesn't continue to move down into the birthing canal. Also, it's important to understand a lot of women are fearful of going to the hospital too early. They don't want to be the one that is like, oh, this is just a false alarm. You're not actually in labor. But it's really not that big of a deal. People, healthcare workers and nurses, and they're not burdened by ensuring that you're not in delivery, right? It's part of their job. They want to make sure that if you are in labor or your membranes have ruptured, that the clock starts ticking right after the membranes are ruptured. So if a woman is concerned or she's having vaginal discharge or she's having pain with contractions, they should be inspired or educated to not feel burdened by that, and that if they're concerned, to go in. Okay, and then the opposite of false labor would be true labor. So again, these are just kind of the opposites. So the contractions are now more regular. They become closer together, stronger, and they last longer. Often, one of the biggest indicators of true labor is that they get stronger with walking. Usually they start in the lower back and they travel towards the lower abdomen. They do not stop with relaxation techniques. The cervix is softening, it is thinning, and it does dilate. And the fetus or the baby does continue to descend down into the pelvis. So that's, of course, the biggest differences there. So, as you can see in this photo here, standard precautions are very common in delivery. Labor and delivery is very messy. There are a lot of bodily fluids that happen in labor and delivery. Providers and nurses need to protect themselves, right? So PPE is meant to protect the worker, right? It does protect patient to patient care, right? So if we wear PPE in between patients, we're not transferring bugs. But ultimately, especially in labor delivery, in this situation, the PPE that the provider and the nurses are wearing is really to protect them. There is blood and bodily fluids. It happens with delivery. It's inevitable. Protections, of course, always begin with hand washing. That's a 101 of healthcare. Things you might see are gloves, waterproof gowns, eyewear, even shields, and again, waterproof front and sleeves of the provider here. So this gown here is likely waterproof. It's not just a paper one. Okay, so we're going to move into the actual process of labor and delivery. There are 5 P's, which are the factors involved in labor and delivery. So the 5 P's, these are important. It's passageway, passengers, powers, position, and psych. So these 5 P's are the things that make the actual process happen. So passageway, what is that? It's the pelvis and the soft tissue, okay? Passengers. Who are the passengers of delivery? It's both the fetus and the placenta. A lot of times people think the only person exiting the body or the only thing leaving is the baby, right? But it is also the placenta, so there are 2 passengers. The powers. What is the power of delivery? It is the contractions. The position of the mother can be varying, and it may be multiple depending on, like, she'll change from one position to the other during labor. Delivery obviously is usually only in one position because that is a shorter amount of time, but laboring moms are going to move into a lot of different positions. And they're going to feel empowered to be in some rather than others. They might be more comfortable in others, but they can be standing, they could be walking, they could be side lying, they might be squatting, they could be bouncing on a ball, a peanut ball between their legs laying on their side. They could even be on their hands and knees. There are a lot of different positions in which women labor and deliver. And then, of course, the last P is their psyche, their psychological response and their psyche. How are they handling the delivery process? Of course, there is a lot of pain and anxiety related to having a baby, and so it is a huge part of that process. So going further into the passageway, photo here is, of course, of a pelvis. So the superior portion of the pelvis functions as the support for the uterus and the fetus during the late months of the pregnancy. These bones aid in directing the fetus into the inferior portion of the pelvis. So the superior is the top outer side, and then the inferior is down in the middle. So these bones aid in directing the fetus into the inferior portion of the pelvis, which is considered the true pelvis. That's down on the inside. These 2 sections are divided by an imaginary line called the linea terminalis, or the pelvic inlet. Specifically, to get a really good picture of this, on page 814, box 27.2, you should look at that. Because this is a recorded lecture, it's hard to show you with my hands where I would show you where that, on this photo, where that imaginary line is. But the textbook does have a photo, so I would encourage you to look at page 814. Again, the difference between the superior portion and the true pelvis is the linea terminalis. Okay, so this passageway, the pelvis, we're going to continue to talk about that. The size and shape of the true pelvis are more important than the false pelvis, right? So the false pelvis is this top, wider, bigger part, right? It's like, oh, a baby going through there is no problem, right? But the true pelvis, the lower portion on the inside, that is what we're really concerned about because it is smaller, right? So the smaller area is what we're concerned, is that baby actually going to fit through that section. So the true pelvis is more important than the false because the fetal head must be able to pass through this section of the pelvis for the woman to have a successful vaginal delivery. This true pelvis is divided into 3 segments: the inlet, the cavity, and the outlet. Evaluation of the size of the true pelvis can be done by palpating, can be by feeling where the bone prominences are, or by a technique called pelvimetry. And a lot of times with ultrasound, they're going to be measuring that pelvic inlet. So there's another photo here on the next slide. This is going to give you a good visual. In the red on the left here is the false pelvis, and then the true pelvis is that inner portion, which is pictured in the blue, okay? So we are more concerned about the true pelvis on that right-hand side. Can the baby fit through that space? So now we're going to talk about the passageway. So the soft tissues of the passageway, what are these? They're the uterine tissues, the cervical tissues, and of course the vagina. So during labor, the uterine tissues, they're a thick muscle of the uterus. That's what's going to be the force of contractions. Like I said earlier, the uterus forces from the top down. The bottom of the uterus is more shaped like a tube, and the top is more like a basketball. There are cervical tissues too that change, right? So I have already alluded to the fact that the cervix dilates and effaces or gets thinner. So with contractions, the presenting part, which is the part that presents itself first into the vaginal canal, um, with effacement and dilation of the cervix, those tissues are changing, right? The vagina, in response to hormonal changes, increases in vascularity and the thickness of the mucosa occurs. There's a loosening of connective tissue and enlargement of smooth muscle, which allows the vagina to open and causes less trauma. The smooth muscles, all of these changes allow it to be capable of stretching to the point of a fetus or a baby exiting again without causing trauma. The perineum as well, the muscles of the pelvic floor are stretched and thinned from the pressure of the baby down in the pelvic floor, so much so that the anus may actually appear to be dilated and bulging, which is when hemorrhoids come into play. But with all the pressure down into the pelvic floor of the uterus pushing that baby down, there is a lot of soft tissue changes that really cause swelling and stretching and even bulging. It's a mechanism that is intended to happen on purpose to allow the baby to be a passenger through this passageway. Okay, so like I said, we're going to move into passengers now. So the number one passenger for delivery is the fetus or the baby. What do we care about on this baby? Most importantly during delivery is the skull. The fetal skull is the largest portion of the body to be delivered. It's the biggest portion of concern. How big is that baby's head and in which position is coming first? The bones of the skull on a baby are not rigidly joined or fused yet, so this allows the bony plates to actually overlap each other during the compression through the delivery canal. As the fetus progresses down through the vaginal canal, that process of the bones kind of overlapping and molding is literally called molding, okay? It's an important definition to understand. The photos here show you on the top, prior to delivery, the skull is very round looking, right? And then while in the delivery canal, it's kind of cone shaped and pushed up. Those bones are soft and non-fused so that molding can happen. Anterior and diamond shaped posterior is smaller and triangular. So in the front, it's more like a diamond. In the back, it's kind of triangular, kind of a fancy way of saying a cone head. And that happens on purpose, right? That is a mechanism that was created for the head to actually be able to pass through the birth canal. So here's another photo. The one on the top left here shows that presenting part as it's going down in. There are specific suture lines on the skull that mold and move on purpose. And then the baby's photo on the bottom left is directly after delivery. That shape of the head is going to go down. You know, it's important to ensure families, if they're concerned about it, they might not notice, but if they do, you can say, you know, that happens on purpose. The skull is soft and those bones are going to go back into place. But you can see here again on the right hand side of this slide that before delivery, the shape of the skull is very round. And then in the front, the second photo here, the front is more like a diamond shape if you were looking front on. And then in the back is kind of triangular in shape. So the bones overlap to be able to pass through. Okay, so the other passenger of delivery here, we've talked about the importance of understanding that there are two, right? So there is the baby, and then there is the placenta. So the uterus is getting smaller with contractions, causing the placenta to separate from its attachment site on the uterine wall. So, okay, imagine a big uterus, right? The baby has exited now, and the uterus continues to contract. that placenta is attached to the wall of the uterus, and as the surface area of the uterine wall gets smaller because the placenta is decreasing in size, it naturally detaches on its own. Okay, so with contractions, surface area gets smaller and it detaches. This typically happens within 5 to 7 minutes after delivering the baby. So contractions continue to happen and it will detach, and the woman will often be told, okay, now give a little push and the placenta will exit. So again, it's indicated by the following. There are from contractions. A lot of times there's a sudden gush of dark red blood into the vagina and outside of the vagina, which means it has detached. That gush comes from the detachment. And then a lot of times there's a sudden lengthening of the cord. All of a sudden, the cord that is attached to the baby is now suddenly longer, right? Because it has detached from the wall of the uterus. And then the woman might experience vaginal fullness, and that's because the placenta is down into the birth canal. So other things to know about the placenta. Which side of the placenta is what again? So we already talked about this, but the dirty Duncan or the shiny Schultz. Whatever side is presented first, like upon delivery, doesn't really matter. However, they do inspect both sides, right? So whether you see the dirty Duncan or the shiny Schultz side first upon delivery, like which side presents itself, is irrelevant. But they do inspect both sides once it is fully delivered. And then it's important to know that delivery of the placenta completes the third stage of labor. Once it's delivered, again, they do examine it for that it is completely intact. So they're gonna look at both sides and make sure that it is, a circular in shape and that there's not a large piece of it missing or is still attached to the uterine wall. We do want prompt separation of the placenta. We want that essential injury to happen and the uterus to get smaller. It's imperative that the uterus continues to contract once the placenta has detached, because otherwise the woman is at increased risk for hemorrhaging. So as it decreases with contractions, the uterus is decreasing. All of these things, again, are excessively important to decrease her risks of hemorrhage. The uterus cannot contract and get smaller if it is filled with blood clots, okay? So on page 820, there's a diagram that goes through how to do a uterine massage to expel clots. So if the woman is after delivery and she's in postpartum, if her uterus is feeling very boggy and it hasn't gone down in size, you may need to massage the uterus externally on her abdomen to get the clots to be expelled, because if the hollow organ is filled, it can't get smaller, right? It needs to expel what's inside of it to decrease in size, okay? Okay, so we're going to move on here to fetal descent. So in what ways do we describe or understand how the baby is moving down into the birthing canal? There are different ways that we describe it. So the attitude, the presentation, and the position. There are multiple different ways. So the attitude, what is this describing? It's the relationship of the fetal body parts to one another, okay? So here is a picture of different attitudes. The flexion in the first photo, A, that is the ideal attitude of the baby at full term. The fetal position essentially is what flexion is. The chin is tucked, the back is bowed outward, the arms are crossed over the chest, the legs are up towards the abdomen. Why is this ideal? It's because it takes up the least space, right? At this angle, the baby is going to exit and approach the pelvis in the easiest fashion, okay? Fetal lie is the relationship of the cephalocaudal axis to the mother. So in relation to what position is the baby in comparison to the mother's axis? Longitudinal is the spine is parallel to the mother's spine. Transverse lie is when the baby is perpendicular or side laying in comparison to the mother. Only 1% of births are transverse. Why would that be? If the baby is perpendicular or side lying when it's trying to exit the birthing canal, you can imagine how traumatic that would be, or how damaging that would be to the vaginal canal. It is better if the baby is in a longitudinal lie. So what is fetal presentation? This is described as the part of the fetus that enters the pelvis and lies over the inlet and comes in contact with the cervix first. So fetal presentation or presenting part. 96% of all deliveries, the presentation is cephalic. What does that mean? That's a fancy way of saying that 96 deliveries are head first. Cephalic presentation is that some part of the head is in contact with the cervix. Cephalic, it's important to understand that cephalic presentation can be 4 types, okay? Vertex, which is between the fontanelles, that's vertex position. It can be brow, face, or chin first. So much like this photo up here in the top at A, B, C, or D, that's going to be a difference of whether it's brow, face, or chin, right? So in D, the baby's chin is essentially what is hitting the cervix first. It's still a head first delivery, but the baby is not in flexion, okay? The portion that enters the birth canal first greatly impacts the progression and the outcome. The diameters of the first picture A and D are different. The baby's chin coming out first makes there to be a wider portion. It's wider as it tries to exit the vaginal space. 3% of deliveries are breech. Breech is bad. Breech means feet first, okay? C-sections are a lot of times necessary with breech deliveries and with transverse lie because what's coming first out of deliveries, elbows, shoulders, hands, hip bones, if that's what's coming out first and that's what's trying to exit the cervix, it's very, very difficult and dangerous for the baby's body to try to exit the mother's body in that position. So that's why I put here elbows, shoulders, hands, hip bones. If those are trying to present first, that's bad and almost always indicates a C-section. Okay, so fetal position, the position in the relationship of the presenting part to the quadrant of the maternal pelvis. So this can be determined by what we call Leopold's maneuver. So that's a bimanual maneuver where they're feeling for the position of the baby by palpation. So they're using their hands to try to determine what position is the baby in. This can be further elaborated on page 817 in box 27.3, which I would encourage you to look at. These are usually abbreviated, so you're going to see LOA, or there's a whole bunch of them on that page, but the most common is LOA, which is left occiput anterior. Occiput meaning the back of the head or skull. So LOA, occiput, points towards the left anterior segment of the maternal pelvis. This is the ideal position, and presentation is also at this point longitudinal. So the baby is, their spine and the mom's spine are longitudinal. They're matching. The baby is head first and actually facing backwards essentially. The baby is well flexed and in a vertex position. So fontanelles first, chin is tucked, and they are in a longitudinal fashion. Okay, so LOA is the best. So I would really encourage you to look at page 817 because you're going to see all of the different fetal positions that could be. Okay, why is LOA best? Like I've already mentioned already, the head is nice and smooth and round. It's best for enforcing effacement and dilation of the cervix. As you can imagine, a head pushing down on the cervix is going to do a much better job than an elbow, right? Or a hand or a foot. Bones of the skull are meant to be condensed. We talked about molding. They are meant to flex, bend, and shape to the shape of the birthing canal. An arm or a leg or an elbow, they're not meant to mold essentially the same as a skull is. The large head filling the space first decreases the risk for cord prolapse and compression. So as you can imagine, other body parts moving down into the birthing canal, if it's an arm or an elbow or a foot first, oftentimes the the um, the umbilical cord can slip down into the vaginal canal, which puts it at risk for being compressed by just the sheer force of contractions. If parts other than vertex position or if it's not a vertex presentation, labor is almost always longer, more tiring, and there are poorer outcomes. Okay. So like I just talked about cord prolapse. So if the head is not filling the vaginal canal and instead a leg is coming first, cord prolapse is a complication of delivery, okay? Prompt recognition of prolapse is imperative. Pressure on the vessels of the cord directly affects the baby, because as that umbilical cord is being compressed, so is blood flow, okay? Fetal hypoxia is what happens when the cord is compressed, and fetal hypoxia is bad. Occlusion of blood flow to and from the fetus greater than 5 minutes almost always can result in central system damage or even death. Cord compression can be lethal. How do we manage it? So there are ways that you may even see in delivery at clinicals, but there are a lot of great videos out there. These are just a few diagrams or photos shown here in the slide, but the examiner can manually relieve pressure, so a hand of one of the nurses or the providers may actually be placed up inside the vagina, holding pressure against the vaginal wall so that the pressure on the cord is relieved. So they may be pushing back the fetal head to come up off the cord. That's usually done in an emergency. So of course that's very uncomfortable for the mom. Sticking an entire hand up into the vagina to relieve pressure from the fetus that's wanting to exit the body. This is not a comfortable thing for a mom, okay? But it's being done to save the baby. Sometimes women will be put into a modified Sims position or knee to chest, which is what you're seeing in that diagram. What that's doing is forcing gravity to come into play here. So the baby, instead of coming down into the birthing canal, is kind of by gravity being pulled back up into the abdominal space, hopefully naturally relieving pressure on that cord. If they're unable to relieve the pressure or slip the umbilical cord back up into the uterine space, C-section is indicated to relieve pressure and to decrease death and or central nervous damage, okay? Okay, so we're moving into the third P of the 5 Ps, and that is power. So there are primary powers and there are secondary powers in labor. Primary power is the involuntary contractions that originate at certain pacemaker points in the thickened muscle layers of the upper uterine segment near the fundus. This is responsible for effacement and dilation of the cervix. What is effacement again? That's the thinning of the cervix, okay? Typically it's 2 to 3 centimeters long and 1 centimeter thick. Only a thin edge of the cervix is palpable when effaced. So normally it would feel thicker and like protruding, and when it's fully effaced, you can hardly feel it at all. When we're describing effacement, it's either 0 or 100% effaced. And then dilation is when it widens and opens from pressure from the presenting part, which is typically the head. Secondary powers in labor are the involuntary urge to push, and second powers secondary powers are initiated with bearing down effects, diaphragm, and abdominal pushing. These really have no effect on dilation, but are immensely helpful once dilation and effacement have already occurred. Typically, secondary powers are most effective in the second stage of labor. This is when the woman feels like she needs to push and she's assisting in labor. So primary is it's happening on its own, essentially, and secondary is her urge to assist and to push. Contractions, remember, in early labor are 15 to 30 minutes apart and last 20 to 35 seconds. And then later in labor, they're only 2 to 3 minutes apart and last longer, roughly 60 to 80 seconds. Okay, so moving into the fourth P of the 5. So positions. Hello, gravity. As you can see on this photo here, there are tons of positions in which women may labor. Squatting or using a semi-seated position is more effective than laying on the back, essentially. Abdominal muscles work in greater synchrony with contractions during bearing down efforts. So when she's bearing down, the abdominal muscles work better if she's not laying flat on her back. Sitting up, being more upright, also improves the mother's cardiac output. And of course, it's important to know that changing positions helps reduce fatigue. It increases comfort and improves circulation. So women labor for many, many hours. Some women are in labor for 30 hours. So you don't want to be laying in one position for that entire time. Walking, sitting, squatting, bouncing on her hands and knees, or bouncing on a ball or being up on her hands and knees are going to help. So, and then of course, lithomy position is most common for the actual delivery, which assists the physician in catching the baby more safely. Okay. So to review, passageway is the pelvis, essentially. Passenger is who's going through the pelvis, the fetus, and the placenta. The powers of pregnancy are both primary and secondary. Positions, knowing that gravity is going to help and that there are multiples that can be done, but that the lithomy position is essentially how most women will deliver. And then psych. So the fifth P is how is her demeanor? How is she mentally doing? Labor is exhausting and a huge mental game, essentially. And so you're there to help decrease her anxieties and her fear. She's very fatigued. Their psyche has a lot to do with their ability to cope with pain. And you are there to help coach them. So these are, in review, the 5 Ps. Okay, so we're going to move into the mechanisms of labor. So this is essentially what movements really happen with every delivery, okay? So we're going to go through them. Engagement, descent, flexion, internal rotation, extension, external rotation and restitution, and then expulsion. So this is visually, if I was standing in a class, I would be using my hands to talk you through this. So I'm going to describe some of these, but I would very much encourage you to watch some videos out in the mechanism of labor, because this will make a lot more sense once you get a visual for this process. But engagement is when the head crosses the inlet, the pelvic inlet. This often happens before labor begins. This is when women feel the baby drop. Descent is a downward progression of the presenting part, which is essentially the head in relation to the mother's ischial spine. Okay. Flexion is both primary and secondary. Then internal rotation, the fetal head turns to progress through the pelvis. Extension is when the head passes under the woman's pubic bone. External rotation and restitution, the actual delivery of the head is done by extension, and when it's delivered, the head realigns with the shoulders and bodies, which is restitution. The body kind of turns, so the head will exit the vagina and the body will actually turn to realign. Expulsion, the body and the infant leaves the pelvis. This is rapid once the head and shoulders are delivered, okay? So this process again is very visual, and there are videos for this, so you do need to look at them so that this makes sense. Okay, so after you've reviewed those, again, we're just going to review the these are questions that hopefully based on the last 50 minutes of content, you know what they are. These are high points, the 5 Ps. What are they? What is nitrazine paper? Why do we use it? How do we use it? Why is it important to know when the membranes rupture? And then what is the ideal fetal position? Those are questions that you need to be able to answer. Okay, so like we just talked about, this is the mechanisms of labor. This transition here was because this is for the second day of PowerPoint. So we just went through those. I'm not going to go through them again, but it's important that you do watch a video for that, okay? There are links here that show these maneuvers, okay? On the right-hand side, you can see a good visual without a video, but this is each mechanism of labor in a video, in a picture, okay, in a still picture. But I would still very much encourage you to watch videos on the mechanisms of labor. These are called the cardinal movements, okay? So engagement, descent, flexion, internal rotation, extension, external rotation and restitution, and then expulsion. Those are all the cardinal movements of labor, okay? All right, moving into the stages of labor. The first stage is dilation. This is a lot of times the longest. It can last 10 to 12 hours and begins with contractions to being fully dilated. So from 0 to 10 centimeters. The first stage is 3 stages long. There's the latent phase, the active phase, and the transitional phase, okay? So the latent phase, the contractions are roughly 5 to 8 minutes apart, and dilation is 0 to 3. The mom is anxious, walking, talking, and she's still up and moving usually. The active phase is between 4 to 7 meters dilated. She's usually less talkative, in a lot more pain, and she's more interested in starting techniques for pain control, distraction, breathing, likely even pain management, epidural. Transitional phase is when the body is transitioning into the last phase here. So 8 to 10 centimeters of dilation. Contractions are close, every 2 to 3 minutes. She's usually very internal at this point, deeply focused, a lot of times irritated by distractions or trying to communicate with her. Nausea and vomiting is very common, and pain management usually required or requested at this point. Okay, so the second stage is the delivery of the baby. This stage begins with complete dilation, so 10 centimeters dilated to delivery of the baby. It lasts on average 30 minutes, but can be as long as 2 hours. Once the woman is fully dilated, she'll feel the urge to push. The patient needs coaching at this point because they're tired. The second stage, the actual delivery, they've just had hours and hours of labor, okay, to get to 10 centimeters dilated. So a lot of patients at this point, they're so exhausted, but they're so close. So they need coaching. An episiotomy, what is this? This is less common now than it used to be. It was more common in the 70s with vaginal birth, and now is usually only done if absolutely necessary. Episiotomies are when the physician, when the baby is being delivered, will create an incision in the pelvic tissue to help the baby pass through the canal. Essentially, a surgical incision to open the vaginal canal wider. Obviously, complications related to this are bleeding, healing, pain, infection, and then later pain with sex. This is more of an unnatural process, but episiotomies are essentially trying to prevent the women from having tears. If the baby is doing well and there are no complications, once the baby's delivered, of course, it's the first thing that they do is put the baby to the parent's chest, usually mothers, obviously. In an emergency or immediate responsive care may be needed to the baby or the infant, which is always done in the delivery area. That's why when you'll see in clinicals that there is an infant warmer right in the delivery room, because if they're doing resuscitation to the baby, it's right in the room as soon as they're delivered, right there. If this is going on, you'll need to provide reassurance and explanation to the parents if something's going on with the infant. It's always the parent's greatest fear. If the baby's not immediately brought to the mother, they're concerned about what's going on. So again, communicating with parents and just telling them this is what we're doing. The baby needs oxygen. The nursing staff is doing everything that they can to keep your baby safe. Just describing what's going on. At this point, parents are usually really worried. So, but giving them reassurance that you're doing everything you can is the best you can do. Okay, so moving into the third stage. So first stage was basically labor, the second is the delivery of the baby, and then the third stage of labor is delivery of the placenta. It begins with delivery of the infant and is completed with delivery of the placenta. This is usually only 5 to 20 minutes long. It's much faster. Third stage, the mom is usually just like smitten and distracted with the baby, and so a lot of times the provider will be down waiting, instructing and kind of talking the mom through, okay, now push, this is the placenta, you're almost done. Like we talked with placental detachment, there's often a gush of blood that helps the provider or the nurses know that the placenta has been detached at that point. And then they always inspect the placenta. And at this time too, during the third stage, they're assessing the vaginal canal and the perineal space and repairing any soft tissue damages at this time. So if there was an episiotomy performed or there was vaginal tears with delivery, at this point they're usually repairing that soft tissue damage. Stitches are almost always absorbable. And the average blood loss for women is 200 to 300 mils. More than 500 mils of blood loss is considered excessive. Medications like Pitocin or Methadone are administered for contractions to keep blood loss minimal. So a lot of times medications are delivered to the patient even after they've delivered the baby to keep the uterus contracting. This is extremely important to understand, that the postpartum blood loss is very detrimental, and also as the placenta continues to contract and get smaller, her likelihood of blood loss becomes smaller. We want the uterus to continue to get smaller and continue to contract. And then, okay, moving into the fourth stage of labor, that's stabilization. This is critical time to pay attention. Some women are tired and reserved and want to sleep. Some women are really euphoric and energized and feeling empowered by the delivery that they just went through. Assessment for women is every 15 minutes minimum. This includes vitals, assessing for bleeding, assessing for uterine tone, visualizing the perineal tissue, and assessing vaginal discharge. This is a crucial time for assessing for postpartum hemorrhage. Once the patient is officially stabilized, they are usually transferred at this point to the postpartum floor or postpartum side of the unit. Okay, so let's talk about fetal monitoring. So labor is stressful to the baby, and continuous monitoring is important. So like we talked about in lecture in person, we talked that there was two types of transducers, or two types of devices that go in the abdomen. One is a toco transducer and one is an ultrasound. One is measuring uterine contractions and movement, and one is measuring the fetal heart rate, okay? The normal fetal heart rate is 120 to 160. an increase or decrease of 30 beats per minute should be reported immediately. That would be grossly concerning. So if the baby's heart rate drops 30 beats and it gets below 100, we're concerned. Or if it's up near pushing 200, we're concerned as well. Fetal monitoring can be done externally or internally. Okay, so again, externally is those two devices on the outside of the belly. Fetal heart strips. On a strip, the upper portion is the fetal heart rate and the lower part are the contractions. Fetal monitoring can be done during many parts of labor due to how non-invasive it is, external I should say. So external monitoring is really just the woman is wearing it almost the entire time, especially if in a unit. It's not invasive to place those devices on, and they give us a lot of information. So it's used almost entirely during the entire laboring process. Internal monitoring is a little bit more invasive, and we'll talk about that on the next couple slides. Okay, so here, internal monitoring, as you can see, this is almost like a catheter that is placed up in through past the cervix, so into the vagina, past the cervix, and into the amniotic sac, essentially where the baby is. This is obviously much more invasive. It's a spiral electrode placed on the presenting part to monitor the baby's fetal heart rate. So this is usually placed up and in, and sometimes it's even attached to the top of the baby's head. Intrauterine catheter is used to monitor duration, intensity, and resting tone of contractions. Can only be used in the intrapartal period because it passes through the cervix and into the uterine space. So to be able to place an internal catheter, she has to be in labor, right? Because the membranes are ruptured, okay? And also the cervix must be dilated in order to pass that type of device through, okay? The head of this catheter is large enough that she must be dilated 2 to 3 centimeters to pass the electrodes through. Okay, so discussing fetal monitoring. Decelerations, what is that? So a deceleration is a decrease in fetal heart rate related to contractions. It's important to understand that these can be early, late, or variable. So early decels, late decels are variable. Early can be normal. So when the heart rate dips before the contraction. Late and variable are more concerning and indicating fetal distress, okay? I'll show you a heart strip, so this will be, again, these are things that are easier discussed if you see them. So when we, there's, on the next couple slides, there are some visuals. So when the baby is hypoxic, a lot of times the baby can be tachy or severely bradycardic. Persistent late decelerations usually indicate that the baby is hypoxic. And then severe variable decelerations with slow return to baseline. So again, when we look at a strip, I'll show you what that means. What are other reasons that can cause hypoxia is meconium. When the meconium is when the baby has their first stool inside the abdomen. It stains the amniotic fluid and is caused by a release of the anal sphincter of the baby when it's hypoxic. So a lot of times if there is meconium in the amniotic fluid, it means that the baby at some point was hypoxic in utero during delivery. Nurses are legally liable for understanding how to interpret fetal heart rate monitoring and knowing when to report up to the chain of command. So fetal heart strips are really important to understand what you're seeing and knowing when to be concerned, okay? So on this picture here, the picture on the left, so the fetal heart rate is the top portion of the strip, and then the lower portion is uterine activity or contractions, okay? Fetal heart rate monitoring and interpretation. So these are some really good visuals here. What we're doing essentially is comparing or contrasting how the baby's heart rate reacts in relation to the contraction. So the contraction, think of it as really squeezing down on the baby, and the baby's heart rate tells us how they're tolerating the contraction. Okay, so it's reassuring when the baby's heart rate is going up and down. We want there to be variability. We want the baby to be excited and then calm down. We want there to be changes in the heart rate. Okay, an abrupt decrease in the heart rate is concerning, and especially if it happens after the contraction. So variable decelerations with the onset of contraction, this makes sense. When the baby is being squeezed by contraction and the heart rate goes down a little bit, that's normal. The baby's under stress, but we want it to come back up, right? So, but when the woman is having a contraction and it takes the baby a while after the contraction to come up, the heart rate to come back up, that tells us that the baby is struggling to recover. Hopefully these photos kind of help show you, help give a good visual for what we're looking for. We do want variability. It's normal to see it to decrease with contraction, but if it's late to come back up in heart rate after the contraction, we're more concerned, okay? Okay, so this is another way that we assess the baby. This is the response of the newborn to birth. How did they handle it? And this is called an APGAR score. Being delivered was stressful, not only for the mom, but for the baby as well. So APGAR is a scoring system, 0 to 10, that tells us a lot of how the baby did. It indicates heart rate, respirations, the muscle tone, reflex and irritability, and also the skin color. So they get a point system for each one of these systems, and then again on a scale from 0 to 10, 0 being really bad and 10 being perfect. Okay. It's taken at 2 stages. They're given 2 APGAR scores at 1 minute and 5 minutes of age. Like I said, again, it measures heart rate, respiratory effort, muscle tone, reflex, irritability, and color. Low equals that there's a serious problem and likely that the baby is going to be resuscitated, and a high number means that they're doing really well and they'll just receive routine care. A score of 8 to 10 is considered optimal. What we're looking for is the baby grimacing? Is it crying? Activity. What do the respirations look like? How does it generally appear? What's the pulse? So after delivery, the number one things that we're doing is we're warming that baby up and we're suctioning. Those are key things that we do after every delivery. Airway, it's important. The baby's airway is full of bodily fluids. It's important, very important to suction. They're almost always going to use bulb suction, but sometimes they'll do deep suction depending on the status of the baby. If they're moving air well and they're able to clear their own lungs, the bulb suction is appropriate. But we're helping the baby remove that amniotic fluid from their mouth and their airway. We always suction their mouth first and then their nose, because when we suction them, they're going to gasp, and we want to get that fluid out of their mouth. A bulb suction. So it's important to know how to use it. For it to suction, you have to compress the bulb, put the end of the suction device in their mouth, and then release. That's how the suction device works. And I explained that, and you might be laughing or chuckling, but a lot of people don't know how to appropriately use that. So during vaginal deliveries, babies' mouths and lungs are squeezed of fluid. So when they go through the birth canal, their body is really put under a lot of pressure. And during C-sections, that's not the case. So a lot of times C-section babies need more suctioning. And again, it's imperative that we warm the baby. We must warm them up. Body temperature drops quickly. In utero, they're used to 90 degrees. Well, in a surgical room or an ambient room, it's about 70. So they're going from a 20 degrees difference, and they are wet. They're all wet. So we need to dry them and warm them up. Contact heat is perfect. The mom is radiant warmth, and so a lot of times right after delivery, the first thing they're doing after they're drying off the baby and suctioning is putting them on the mom's chest. Okay, so after the baby is resuscitated and or suctioned and warmed up, right afterwards, if there's no complications with the baby, we always footprint and we always hospital band the baby right after delivery. They're wanting to make sure that they have a band that indicates that this baby belongs to this mom. Okay, so moving into health perception and management. So we've talked through labor and delivery, the process, the stages. We're going to touch a few other topics here before we close out this chapter. So health perception and management. It's important to understand how prepared a mother is for childbirth. Is she going to have a hospital delivery? Is admission expected? Paperwork can a lot of times be done early. Bags and car seats should be packed and ready weeks in advance because nobody really knows the exact date that the baby is going to arrive. So this picture here is just an example of things that might be in a hospital bag that a mom has ready for delivery. Okay, so what about metabolic and nutritional needs during labor and delivery? It's important to understand that gastric motility in the gut slows down, which can increase nausea and vomiting, unfortunately. When did they last eat? You should care and know if they're going to be getting anesthesia or end up in a C-section. Small amounts of water or ice chips might be acceptable by the provider or per the provider due to the exertion of labor. She's doing a lot of physical work to have a baby, so some providers are comfortable with sips of water. IV fluids are normal and are more the way that women get hydration and to prevent dehydration. Why are they NPO during labor? They're NPO during labor because in case they end up in a C-section or needing anesthesia, they are safer, decreasing their risk for aspiration. So we prevent them from eating in case that happens. Okay, so elimination during delivery. Urine output may be normal or even decreased. Voiding every 2 hours is desirable because we've talked about this concept before, but a full bladder makes the uterus elevated. It makes it harder for the baby to pass through the pelvic inlet if the bladder is in the way. So it can interfere with the progress of labor. Some women experience diarrhea with the onset of labor. With the increase in abdominal cramping, sometimes diarrhea can happen. Careful hygiene technique is important to reduce possibilities of contamination. So a lot of nurses are helping clean up women. Stooling during delivery is completely normal. Enemas are now no longer a standard practice. Okay, so we've kind of already touched on this already, but activity and exercise. Walking is encouraged. Changing their position and getting up and moving is helpful. Walking also provides distraction with pain or analgesics. Rest is recommended. So if her pain is very, very intense, then walking around is not necessarily recommended. It's very common to have low back pain. Changing in positions are helpful. And also warm showers can be given for back pain. If she's early on in her delivery, helping her get into the shower might help with being a distraction and also pain management. Okay, so vaginal exams. These are done to assess for discharge and to assess the progress of labor, specifically the first stage. And then, of course, during delivery, there's so many fluids and things happening and leaking of amniotic fluid that just change the linens as necessary. That's going to happen often. There's continuously going to be changing the bedding. Okay, so the psychosocial and emotional portion of delivery is immense. Every woman copes completely differently. A lot of people have different pain tolerances. Women believe they can be in control of what happens, which can sometimes be defeating because delivery is just one of those wild cards that they might have intentions or expectations of how they want their baby to be delivered, but but it happens otherwise. Fatigue and pain vastly decrease the ability to cope. So the more fatigued you are, the less likely you are to be able to manage pain. Well, labor is extremely fatiguing. So, of course, as the labor prolongs, their ability to manage fatigue and pain decreases. It's the nurse's role to support the woman and her support team, okay? Fathers or the father figure, they're going to see and experience something they've never seen. Don't let them be your patient. Explain to them what's coming, what they're going to see, instill confidence in them, and also let them know that if they're not feeling well, they should sit down or step out. Page 837, box 27.6 goes through some points for dads and how to encourage them. In general, people need encouragement and support. They need help knowing how to help their woman who's laboring. Sometimes they feel helpless with knowing how to help her. So whoever's in the room with her might need a coaching as well. And then if the woman is alone, the nurse's role is much more heavier in moral support since there isn't someone else there with her. We've touched on this topic before, but some women will hire doulas. What is the definition of a doula? Technically, its definition is a woman servant. Women who are supported by doulas are less likely to require pain medication. They receive Pitocin. They're less likely to receive Pitocin and less likely to deliver via C-section. Women also show an increase in maternal and infant bonding. Doulas are trained in therapeutic touch, counterpressure, breathing patterns, and they serve as immense emotional support. Their goal and their position, they do not administer medication. So their goal is to keep the woman happy and to help administer whatever her birth plan is. But doulas do not administer medications. If you're in a birthing center or a hospital that is more equipped like a birthing center, some of the doulas are employed by the hospital, but most cases they're hired independently. Okay, so psychosocial, some other points of topic here. So a well-informed father or support person can make a significant contribution to the health and well-being of the mother and the child. They are also needing to be involved in the education. They are going to be there for the woman after you during postpartum, and they know what she's been through, so they are also needing your support. It's important to understand that the history of sexual abuse can be complicated due to the nature of the exams needed during delivery. You need to explain your next steps, remind that pain and sensations are related to childbirth and not past abuses. Sometimes women are really going through so much pain and trauma that they're coordinating past abuse with pains similar to delivery. And that can obviously be very complicated. Childbirth can trigger previous traumas due to loss of control, pain, and emotional fatigue. So some women really lose sense of control and reality and might be really emotionally absorbed by previous traumas, and childbirth is just so intense that it can really trigger some of those previous experiences. It's important and imperative to protect women's privacy, allow them permission, and accept her reactions to what she's experiencing. Labor and delivery and having a baby is just such a sacred experience, and everyone's is different, but it's your duty as a nurse to protect her privacy. Women in general that have had babies prior, their deliveries after their first they usually have more confidence. They know what to expect or have an experience prior to this one that they're just less fearful. Women who have previously complicated pregnancies or deliveries will need more assurance that they are capable. So with that being said, confidence can be gained if they've had previous uncomplicated pregnancies, but if they've had previous pregnancies that were ended in traumatic experiences or ended in emergencies, they might need reassurance that they're capable of having a safe delivery. Remember to be open-minded and empathetic, understanding to cultural differences and practices. What you are comfortable with might not be what type of patient population you're serving at that moment, but your duty as a nurse is to provide the same medical care to each patient regardless of your implicit biases. Is there a language barrier? Call a translator. As you can imagine, there's a lot of communication that goes on with labor and delivery, and a language barrier would make this just that much more intense. Use your resources. And then, of course, pain management may be necessary for coping. So not all women are going to want a natural birth, and that is just fine. Okay, so on page 839, there's a box 27.6. It goes through different types of pain management. Epidural blocks and spinal blocks are definitely the most common. These can be single dose or they can be continuous. Those are the most common. Then there is paracervical, pudendal blocks, and saddle blocks. And then, of course, there is general anesthesia, but that is less ideal. General anesthesia, as you're aware, is systemic pain control that involves loss of consciousness, that involves intubation. It's rare for vaginal births. If spinal blocks or epidurals fail, but a C-section was required, then they will use anesthesia. Or if there's an emergency C-section required from a vaginal delivery going bad, but there's no spinal block or epidural in place, then they will use general anesthesia. Complications for general anesthesia is maternal gastric aspiration. So moms that have had any fluids or anything to eat, they're worried about her aspirating. And then anesthesia relaxes the body, so uterine relaxation can happen with general anesthesia, and that is complicating postpartum and the likelihood of postpartum hemorrhage. So those are different types of anesthesia or pain management that can be used, but again, I would encourage you to look at page 839. Okay, so what is a precipitous birth? It is essentially an emergency birth. Precipitous labor or emergency birth is when it lasts less than 3 hours from the onset of contractions to the time of delivery. Under 3 hours, so from 0 dilation to 10 delivery of the baby is under 3. That is very quick. It may result in a hypertonic uterine contractions, so just really, really intense, really strong contractions, okay? Maternal complications include uterine rupture, lacerations of the birth canal, amniotic fluid embolism, and postpartum hemorrhage. All of those things are really, really scary and unfortunate. So when the baby is just being forced out of the body, the tissues are not able to stretch like they do over 20 hours of labor. So that's why there's more tears. And then also, how is the baby compromised during a precipitous delivery is they often suffer from fetal hypoxia or intracranial hemorrhage. If they're being forced very quickly through the birthing canal, it's just less of a due process, and there's more risk associated with this. Okay, so inductions. There are a few different ways that we can induce labor. So if the woman is not going into labor herself, an attempt to start labor can be forced on. It may be necessary when the membranes have ruptured longer than a few hours, but she's showing no signs of delivery. Remember, if the membranes of the amniotic sac have ruptured, we have 24 hours for that baby to be delivered. So if the membranes have ruptured and she's not in any form of labor, they'll use different things to induce it, okay? We also may induce if the amniotic fluid is low, or if they have a history of intrauterine growth restriction, stillbirths, or hypertension disorder. So if there is complicated histories with deliveries, induction may be merited, okay? So there's 3 different ways that we can induce here: an amniotomy, or prostaglandin gels, or oxytocin. So an amniotomy is a manual or artificial rupture of that amniotic sac. Internal monitoring can be placed once this happens, but requires the woman to be 2 to 3 centimeters dilated. We always assess fetal heart rate for a full minute after we rupture membranes, and then we assess the amount and the color of the amniotic fluid. Remember, 24 hours starts as soon as the sac is ruptured. Different prostaglandin gels. Essentially, they're a cervix softener or a cervix ripener. Before administration of these, we want to always assess what is the fetal heart rate prior to administrating. Contractions typically start within an hour after applying these types of softeners and gels. An amniotomy is usually done in conjunction with this gel, so a lot of times they'll rupture the membranes, apply this gel, and hope that contractions start to kick in. And then oxytocin or pitocin, this is an IV medication or stimulant, can be used with uterine inertia. If they're absent or weak contractions, we'll use oxytocin or pitocin. It's always given IV, and it's titrated based on the characteristic of the contraction. So we just turn it up, increase the dose until we get strong enough contractions. We always monitor the fetal heart rate for this, and know that Pitocin can elicit, really, the job of Pitocin is to create contractions, but they can be very strong and painful for a woman. A lot of women who go through delivery who need Pitocin are like, oh yeah, Pitocin, it's so painful. Essentially, it's doing its job, right? So on this next slide, it shows some different tools or hooks that they'll use to create an amniotomy. So on this slide, there are different hooks or devices where they're inserting into the vagina and past the cervix to rupture the sac. They're like a hook or a crochet hook almost. Some are like a longer hook, and then some go on the tip of a finger. Again, these devices are used to rupture the amniotic sac. Okay, so when do we intervene? So sometimes deliveries need intervention. Sometimes they're just not progressing, or the baby is now in the birthing canal and they need assistance. They can't get the baby to be passed through all the way. Okay, so there's multiple different ways. These are just some of the most common. So a forceps delivery. Forceps are like spoon-like devices that essentially fit around the baby's head. I'll show you some pictures here, and there are great photos in the text. We use forceps if it's a prolonged second stage of labor. It really helps us essentially grip onto the baby and help pull. Anticipated fetal issues. So if we're worried that the baby's going to be having issues, we'll use a forceps to kind of move delivery along. The head of the baby must be engaged into the birthing canal. The baby can't be up floating in the uterus. They have to be down in the birthing canal for this to be successful. Lots of babies, of course, have bruising from this device. You'll see photos and understand why. Maternal damage can also happen. I mean, we're using a very aggressive, like metal form device up into the vaginal canal, which can cause increased bleeding, even bruising, and can cause the need for episiotomies. Vacuum assistance. So that is exactly what it sounds like. It's a vacuum cup that is attached to the top of the baby's head when the baby's in vertex presentation. We don't apply these to the bottom of a baby. Like, we're not going to put it on the baby's leg, right? It would be on the top of a baby's head. So, and then this vacuum assistance is always used once the membranes are ruptured, obviously. She has to be completely dilated and the mother is still pushing. At this time, we're always going to assess fetal heart rate because we want to make sure that the baby is tolerating the usage of the vacuum. Babies a lot of times experience swelling, or what we call kaput, on the top of their head. It's essentially scalp edema. It's always temporary, but when you're applying an actual vacuum to the top of their head, of course they're going to get fluid and edema under that location, okay? And then, of course, another common intervention is a C-section or cesarean. C-section, if you're not familiar, is the delivery through the abdominal wall. It is surgical. It's actually a very invasive abdominal surgery. It can be scheduled or it can be emergency. So some women have scheduled C-sections for deliveries. 30% of deliveries end in C-section, which is actually a pretty staggering number. Considering the body is meant to deliver vaginally, 30% ending in C-section seems high to me. Complications of C-sections include infection, hemorrhage, accidental injury to the bladder or the bowel when they're making incisions, and then injury to the uterus, of course. Indications, why do we do C-sections? If the baby in the pelvis of the mom are disproportionate, like if the baby's too large to go through the birthing canal, they'll just schedule C-sections. If she's had previous C-sections, then she's a candidate for another one. If the baby is breech, if there are maternal cardiac issues, if the baby's hypoxic, if there are infections, if there's pelvic anomalies or abnormalities, poor presentations, like if the baby is delivered transverse, or like if the baby is not in the right position, and then of course also if there are congenital anomalies or we're expecting there to be complications with the baby upon delivery. Sometimes they'll elect to have a C-section. This slide here shows some of the different things that we talked about. So the forceps delivery is the two left photos. Again, these are pretty invasive devices. You can see why there would be bruising both to the baby and to the mom. And then the photo in the middle, the two middle ones, is vacuum assistance. So of course you see that vacuum attached to the top of the baby's head. Of course there's going to be edema under that vacuum assistance, okay? And then the photo on the right is actually an abdomen that has been cut open, and that's a picture of a C-section delivery. So one thing I wanted to bring up to make sure that you knew what it was a VBAC. So I kind of alluded to it, but if women had C-sections prior to this, they're almost always going to have C-sections again. Like there's a phrase out there, once a C-section, always a C-section. But certain providers that are comfortable with allowing women to have vaginal deliveries after a C-section delivery. So say they've had their first baby, the delivery was complicated, it went too long, and she ended up in a C-section, but her second child she wants to attempt to have a vaginal delivery. It's 60 to 80% of women have successful VBAC deliveries after C-section. The provider really has to be the one to help make the decision. It really is very dependent on her success or her potential success, depending on why did the previous delivery not go well. And then also VBACs are very dependent on abdominal incision healings of her previous delivery. So we want that suture line and incision to be very strong, because during a vaginal delivery after a C-section, that uterine wall and the abdominal wall is compromised from that previous C-section. And so we need to make sure that she's physically fit and that incision is healing well so that the VBAC goes well. Okay. And then of course, a lot of providers will, if they're comfortable with attempting a VBAC delivery, which is a vaginal delivery after C-section, they can always convert that vaginal delivery into a C-section. Say they're going to attempt a vaginal delivery, but during it's not going well, they can always convert it to a C-section. As far as abdominal incisions go, a good candidate would have had a low transverse abdominal incision. They're not a good candidate if they've previously had a T incision or they had labor dystocia. So a lot of C-section deliveries now include a very low abdominal transverse incision, but even like 10, 20 years ago, they used a T incision where they would the incision was much larger and a lot more risk for rupturing. So, okay, that was a lot of information, an hour and a half of content crammed in. So hopefully this was helpful. Again, it is recorded so you can listen to it more than once, and we will have time to ask questions. If you If you would like to email me questions you have, go right ahead. I'm available by email, and we will review a couple of concepts together based on this lecture once we meet next in person.